shared this link with the MSF from who have an office in Mumbai. And as you know, Medicine Sans Frontiers is actually winding their operations in India, but they have done a lot of work in private public sector marriage in Mumbai for management of tuberculosis. And I took this opportunity to call them because it's important for them to also listen to Dr. Nair, who's so passionate about integrating palliative care in tuberculosis. So, in order that we can all work together, I thought I'll invite them. So Dr. Aparna Iyer, who's also a pulmonologist, is joined this session. But over to you, waiting to hear you, Dr. Nair.
Thank you, Dr. Ajam. I feel a bit, inadequate myself when Dr. Ajam is there to cover both aspects of TB as well as palliative care. So, but
Not
then,
at all. We have lots to learn from each other, and it's always lovely to listen to you.
thank you. But then, like she said, I'm passionate about TB. So let us start. I hope my slides are visible and that I'm audible.
Yes, sir. Yes, sir. You're audible.
Thank you. Thank you so much. So basically, today I'm going to discuss TB and palliative care. I must thank Dr. Ajam because my first formal interaction at a major fora where I was talking TB and palliative care was because of her. So we did that in Bangalore, and since then, like she said, it has been a journey. It's a learning journey. Still a long way to go, but then we are still trying. Uh, we are not really anywhere near claiming that we have done anything for palliative care and TB. With that background, if we go ahead. So basically today, in the time that I have, my plan is that we'll be discussing a bit on why we need to think of palliative care in the context of TB. We'll discuss a bit on what are the gaps, what are the necessities which would actually lead to better palliative care in our TB patients. So I'll be thinking more from the TB perspective, but then I'm also putting in a couple of slides, maybe looking at the palliative care team on what they should be thinking of when they're dealing with tuberculosis patients. And finally, I'll conclude by discussing what is actually happening in the country, in the TB program of the country, in terms of integrating palliative care and TB. Dr. Ajam is also part of the team which is trying to do that. Very small steps now, but then we'll be discussing that later. So this is a slide that starts most of our presentations, and if you look at it, you can see that the numbers are staggering. So we are talking in terms of huge numbers, almost like 1 crore cases every year in the world, patients who develop tuberculosis, out of which about 11 lakh die every year due to 1.1 million, which is more than that. So die of TB every year in India. We have about 28 lakh people developing TB and about 3.3 lakh dying of TB. So huge numbers, and often the politicians, the bureaucrats, and often even doctors are not really aware of these numbers. It's a fun time for me when new MBBS students come for a class, and I ask them how many cases of TB would be there in India every year. And they talk in terms of 1,000, 2,000, 10,000. Some of them dare to go up to a lakh. But then when they hear that there are 28 lakh cases occurring every year in India, that 3 lakh plus die every year in India, when they thought that the whole TB burden in the country was like 10,000. So when there are 3 lakh dying in the country, it's shocking for them. We have the added problem of HIV TB. HIV itself, as you know, is an area where palliative care has a big role. And then you have the problem with multi-drug resistant TB, where the suffering is much more for the patients. And of course, lastly, you have the group of children with TB. Now, all these mortality that we're talking of, large number of people dying, most of these mortalities, a chronic, drawn-out process of mortality. I've been attending a palliative care series of classes, which the Kerala University of Health Sciences has been doing recently. And throughout, the theme has been that, at the time of death, even though palliative care is not to do just with death, at the time of death, give them some dignity, give them a, proper way to die, which is something sadly most of these TB patients lack. In terms of TB diagnosis and treatment, we have gone a long way. So today, if you're looking at the diagnosis of TB, sitting in India, we have all the tests available which are required for the diagnosis of TB. You just forget there was a time when my close friends used to make fun of me that all that you have to offer is a smear microscopy. But today, leave alone those smear microscopy and X-ray, you're looking at all the molecular tests for TB, liquid culture for TB, even whole genome sequencing is available in India, and it is available in the TB program. So today, the state difficult to treat clinic for Kerala, which actually discusses the very difficult cases, was discussing a very difficult case in Ernakulam, where the patient started with pulmonary TB, then developed TB meningitis, and the patient is being worked up. So we found it funny that one of the leading private hospitals in Ernakulam actually has done a lot of investigations while evaluating for TB meningitis, but has written that gene expert could not be done because the patient cannot afford. We found it very funny because the amount of money spent on all those investigations would run into tens of thousands, and the gene expert even done in a private sector costs only 2,500 rupees, whereas they could have just sent the sample across the road to the district TB center and they would have done it free for the private hospital for the patient. So all these investigations, not only are they available in India, but they're also available free of cost. I've been attending meetings all over India, and I often see microbiologists saying that your patient can get a whole set of investigations done for about 25,000 rupees, so make them do it. But then the program is offering all of them free. So they have access to all the best investigations which are done wherever you go in the world. These are the go-to investigations for your TB patient. And in terms of treatment regimes, again, if you look at the regimes that we have all the latest possible regimes which are there in the world, anywhere in the world. Of course, the US and or many other countries have now moved to a 4-month regime for drug-sensitive TB, shorter regime. But then, the evidence for that regime still has to evolve in India. Uh, it's just a, what do you say, non-inferiority study, which if you look carefully, our traditional regime still looks better on that. Anyway, all said and done, we still have the best regimes in the world. All these drugs are available to your patients, including bedaquiline, which is the most costly and the newest drug that is accessible to us. And some of the other new drugs are also coming in. And all of them, again, free to your patient and readily available for the 28 lakh patients who are there in India. So in terms of diagnosis, in terms of treatment, we have it all. And then you have a kind of, can I call it arrogance, which means, we get a feeling the people working in TB and in the health service believe that, we are doing everything for our TB patients. But then that is not the reality. We are not doing enough for our TB patients, in fact. So why should we think beyond those tests and drugs? Because despite all these tests and despite all these drugs being available, still more than, about 3.5 lakh people, 3.5 lakh people dying in India every year is not a thing to be proud of. And despite all the advances, TB still remains in the top 10 causes of mortality. Such a large number of people are dying. Now, the program often reports the success rate or the cure rates, which is almost 85%, which is what the programs aim for. But even when that is reported, even among these 85%, there is a lot of pain, suffering during treatment and after the treatment is over. TB programs generally, until recently used to stop the management of patients as and when they finish treatment. And after that, it's up to the patient to do whatever they do. So the pain and suffering during treatment and after the treatment is over is often ignored by the programs. And that is something that is totally under addressed. Then again, all these drugs are extremely toxic. Until recently, until 5-6 years back, I used to say that the drugs that we take for drug sensitivity, for example, isoniazid, rifampicin, pyrazinamide, all of them are hepatotoxic, can cause hepatotoxicity severe enough to kill the patient. So the drugs themselves could kill the patient. I used to say that ethambutol is a safer drug, but of late, a lot of ethambutol toxicity is also being reported in India now that we moved to a daily regime. And then people are losing vision, and there's a huge debate, whether dying is better or losing your vision is, where do you choose? And ophthalmologists, my colleagues would say that losing your vision is worse than dying, so you should not lose your vision at any cost, even if the patient dies. So these are all difficult choices. Often we sit down with the patient and speak to them, tell them about all this, that if you don't take treatment, there's a 50% chance of mortality. If you take treatment, there's a 7% chance of hepatotoxicity. There's a 25% chance of arthralgia. There's so much percent chance of visual. So these discussions are always there where you tell about risk benefit and try to explain it to the patient in the simplest possible terms. But the reality is that drugs are not very comfortable to take. And I mean, if I can call myself a healthy person, a hefty man like me would actually need to take 6 big tablets together every day, which is not a very comfortable thing to do, even if I don't have any side effects. And then TB is always associated with comorbidities and often complications, and these also cause a lot of suffering in our patients. So it's not all about tests and drugs and cure rates. It's a lot of suffering and difficulties that our patients go through, which is something which is often not recognized, often not addressed. And that is why we need to think beyond these tests and drugs. We had done a study in covering the entire Ernakulam district where we looked at TB patients 7 years past treatment. You know what actually happens to them afterwards. So when you look at them 7 years after treatment, you find that a significant proportion of your patients who are cured, where you thought that the TB was gone, die afterwards. So and we compared this actually with sorry, you can get the point. Anyway. So if you can look at the last column there, we had a similar study in population in Kerala, where it is a general population. And if you look at the mortality among the second last column, you can see that the mortality among cured TB patients is almost 4 to 5 times the mortality which actually occurs in the general population. So they die faster and they suffer more. So this is something that is often not recognized. Of late, of course, the TB program says that your patients have to be followed up 2 years past cure with 6 monthly follow-up. But then that is not really happening anywhere in the country in the field. So this is something that we ignore, that your patients, you think that you've cured the patient, but then the patient is going to die even after the cure. Now, in the context of palliative care, whenever you talk of palliative care, I must tell Dr. Rajan that whenever I attend palliative care trainings, I feel a bit disappointed that often the focus goes to cancer. And when you talk of respiratory diseases also, the faculty often think of lung cancer. So lung cancer and palliative care is something that everybody knows. It's quite well addressed, and we know a lot about what is needed, what to do, and all that. Because off late, you started thinking of other diseases like COPD and all, where there's a lot of suffering. People with going for respiratory failure, they go in for extreme debility, muscle loss, skeletal loss, and all those problems, extra, pulmonary effects which happen. Interstitial lung disease causes often more suffering than a patient with lung cancer. And bronchiectasis also similarly can lead to so many problems. So we know that these chronic diseases need palliative care, and of late we are addressing to an extent the palliative. I would say that not to the extent of lung cancer, but at least to an extent, we kind of think about these diseases and address them when it comes to palliative care. But then when it comes to tuberculosis, it's far behind these other lung diseases in terms of reaching palliative care. So that is a reality that we have to recognize, that tuberculosis doesn't really get that kind of importance. But is it important when you compare to other districts? So worldwide, when you talk of lung diseases, lung cancer is going up the list. You can see it's one of the top 10 causes of mortality in the world. And tuberculosis, which was in the top 10 of cause of mortality about 20 years back, has now really gone down and has gone out of top 10. Of course, that is also because patients with HIV and TB who die are classified as HIV deaths, because the HIV program is more powerful and they want to count the deaths as their own. So people even fight for deaths. So, but then if you add those TB, HIV deaths to TB, then again TB will go into the top 10 causes of death. But then when you come to our country, you can see that lung cancer is not there in the top 15 causes of death. Our people are not dying right now due to lung cancer. Definitely it'll go up the list. At some point, it might go just behind COPD as in the world, causes of death. But then right now in our country, the major cause of death, the second leading cause is COPD, as you can see in the last column. Lower respiratory tract infections going down the list, tuberculosis also going downwards, but still both of them still remain in the top 10 cause of mortality. Of course, asthma is the 13th leading cause of death. So asthma and COPD put together add to a substantial burden of mortality in India. So in our country, when these are the diseases which cause mortality, and these are the diseases which cause mortality which is stretched over a period of time, this is not like people dying immediately. So, it's a chronic death, and it's a death with a lot of suffering. So these are all causes, all of them, including lung cancer, are diseases where palliative care is extremely important for the patients. Now, as I said earlier, lung cancer, COPD, interstitial lung disease, bronchiectasis come on one side, and tuberculosis on the other side is sort of the ignored disease when it comes to palliative care needs. That is also because, the moment you see lung cancer or COPD or ILD, you kind of have a feeling that maybe I can't do much for the patient, which is not really true because of late, patients with lung cancers are, really surviving for long periods. Some of the newer, chemotherapy agents or some of the immunotherapy and all that make our lung cancer patients almost like having a chronic and, you know, NCD kind of disease, with which they survive and they go on with long survival without much of suffering. On the other hand, COPD of still till date, we really don't have any drugs which can halt the progress of COPD. All our drugs are only to reduce the uh, progression and reduce the symptoms and all that. Similarly, for some forms of interstitial disease, even though treatment is very good, sarcoidosis and all, you can probably treat very well. But your idiopathic pulmonary fibrosis, of still is a progressive disease. Bronchiectasis still, if it is not amenable to surgery, still is a progressive disease. So the treating doctor from the very beginning knows that there is no definitive treatment, and whatever treatment we are offering will not lead to any kind of cure. So doctors are willing to consider palliative care fairly early. The moment I see a lung cancer or a COPD or interstitial lung disease, I do think of palliative care needs and consider that they should be linked with palliative care services. Whereas when it comes to tuberculosis, thinking is slightly different. So the physician is often arrogant and believes that he or she can cure the patient. That I can make the patient perfectly normal. In fact, I do tell patients that to make them feel better because nobody likes to hear a diagnosis of tuberculosis. So when you tell them that they have tuberculosis, and they often become very, sad, and some of them start crying, and then you tell them, look at all those patients waiting here in my OP, the COPD or the interstitial lung disease. I have nothing to offer to them. Their disease is going to progress. Whereas your disease, I'm going to give you free drugs, you're going to get fully cured, and I'm going to make you perfectly okay. So that is the assurance I give, which is a false assurance. So, but then I want the patient to take medicines and do well. So you give them a lot of false hope there. So but the doctors often do really believe that they can cure the patient, and they can make the patient perfectly okay. Uh, and throughout, the effort is to save the life of the patient, even till the end. Even when the patient is about to die, you are still trying to save the life of the patient. Whereas in a COPD or a lung cancer, towards when it comes to end of life and all, you know that here our effort should not be to save life, but to give them a proper palliative care, a dignified death, and all that. Whereas here, people don't even think of that. TB is still the very end. You believe that maybe I can cure the patient. And so for palliative care is often forgotten, not really addressed. There's also the fear that, if I start talking about palliative care to a patient with tuberculosis, the patient might feel that the drugs would not work, and that, the patient is not going to respond, that we have given up on the patient, and that would lead to poor compliance with treatment. So you want the patient to take each and every dose perfectly. So there is a need to give them a lot of hope to take those medicines, which is a difficult thing to do for them. So there is a very difficult situation there where you're not sure what really to do. Can somebody please keep track of time for me, because I don't have a timer here, so I'm a bit confused where I'm going with time. Thank you.
It is 6:50.
Okay, fine. Thank you. So look at some of the scenarios. So I just described the scenario overall situation to you, but if you look at these scenarios, you would realize this better. So this man who was actually a government employee, who actually retired at 55. Those days he used to retire in Kerala, and afterwards, because of family difficulties, he was still working as a contractual employee in the same office where he was actually employed earlier as an officer, which is actually a big step down the ladder for him. But anyway, he was working there, and he had what he thought was asthma, and his smear and X-ray and everything were done, which actually looked like this. So the treating doctor at that point made a diagnosis of bronchiectasis. I can't fault the doctor because it does look like bronchiectasis a bit, but then at those days, those private hospitals did not have standardized smear microscopy. These days, these hospitals have a gene expert, so the test would come as positive. But those days, the smear microscopy was better in the government, and this was found to be smear negative. He changed doctors. A new doctor who was a retired professor and HOD of medicine actually did things like Manto, TB, IgG, IgM. IgG, IgM was actually banned later by the government of India. At that point of time, when these tests were banned by the government, 60% of the money spent by TB patients in India was for these tests, which are absolutely useless for patients. So a lot of money is also wasted on all these useless tests for patients. And X-ray and smear, which should have been repeated, were not even repeated. So when you have a Mando negative and IgG, IgM negative, the doctor would believe that patient is not even infected with TB. So why think of disease? So very misleading test. Then he landed up one fine day in my hospital. So I had seen the patient earlier in that stage where I showed you the previous X-ray, and we had a conversation. But the patient believed that he was with better doctors, and he did not even consult me properly. That was in a social occasion. But then he finally ended up in my hospital. My cousin, who was a common friend, and he actually came to me and said, I have a patient in this particular ward. When he mentioned the ward number, I knew it was a TB patient. I said, okay, let us go to the ward. And then the man was almost dying. So the son was standing next to him, and I told him that I'm sorry, your father is in very advanced disease. I'm not sure whether we can save the life, but let us try. We'll give them the best possible treatment and all that. At this point, my resident only had to do a smear, and the smear was 3+3+ smear positive, extremely, infectious patient. The only thing was that this man, being a employee for long, government employee for long, could write government language very well with a very beautiful handwriting. So he was a sought after man to sit next to one of his ministers, to write all the minutes for meetings. I could only hope that the minister would get TB so that some attention would come to our TB patients. So that is a scenario. And I told the son, your father is going to die. But then the father survived. Our medicine really worked. And then the patient ended up with a totally destroyed left lung with a fibrosis in the right upper lobe as well. Now, as Amitabh Bachchan said in a movie, ye jeena bhi kya jeena hai. So, what life is this that you're given back to the patient? So, this man who had a pension of around 30,000 rupees then, I'm talking about like 10 years back, 30,000 rupees, he had a colonization with pseudomonas, which made life very difficult for him. I had to put him on nebulized topramycin, which would take away almost his entire pension would go into that topramycin, and no other income at home. The other cost of treatment and the suffering that he went through. At some point, I did really feel that did I do the right thing by actually saving his life? But then, there are other issues as well. We'll come to that. But the fact is, he really suffered till he died. He was coming regularly to me. He was happy with the treatment, but then he was suffering, and I could see the suffering. Then you have these difficult situations with drug-resistant TB and all, where entire families die of, so first the grandfather died, and then the mother died, and the brother died. Brother, we tried our maximum to save his life, but he suffered and he died. Sister is thankfully better. We did not expect. By the time at the time when Dr. Ajam had called me for my talk, I had made this presentation with these slides. But after 1 year of treatment, more than 1 year now, no? Dr. Ajam Sinfi did that talk at Bangalore. So I think at that point, I thought we were going to lose the sister, but fortunately, she looks. I have a picture as well, which I didn't put up today, but then she is doing well, but still she also has a destroyed. This is the brother's, her brother's X-ray, and you can see that entire destroyed right lung with a pneumothorax loculated with a chest tube in situ. He was suffering. None of the surgeons were willing to touch him because he had extremely drug-resistant TB, and he was a very poor surgical risk case for them. And they knew that if they did a surgery, it would end up with a bronchopleural fistula. But then even for reducing his suffering, we wanted a surgery to be done, but that also did not happen. And he really suffered and died. So we have a lot of patients like this who really suffer because we have no cure to offer for their disease. Often it also happens that the drugs may actually, be effective, and you have the drugs available, but then patient develops hepatotoxicity, then patient develops multiple other side effects, uh, hepatotoxicity, QT prolongation, renal dysfunction, visual problems. One by one, you stop drug after drug. Your consultant specialist tells you, okay, stop this drug, stop that drug. And then you beg, can't we give it for some more time? We have no other drug. Why don't you give some other drug? And then you have to explain there are only like 12, 13 drugs I can play with. I don't have other drugs to give. And then stop drug after drug. At some point, there were no drugs that we could offer to this patient. We could not offer injectable, we could not offer any of the newer drugs. So some of the patients, we reach a stage where giving the drugs. So WHO itself at one point had brought in a new definition which was not there earlier. Drugs stop due to side effects. So that is one of the treatment outcome for TB patients today. where patients suffer so much because of drugs that you forget about treating TB, and you try to reduce the suffering of the patient. Again, only option for this patient would be palliative care. And of course, you have patients like this who don't respond to your treatment. Again, a success story. I just picked up the slide a couple of days back and looked at this. So this 28-year-old lady, engineer doing her MTech at that time, having her third treatment. Each time she was failing the treatment with spinal TB, and there was nothing we could do. We did all kind of evaluation. All of them came as no drug resistance, no there's a borderline malabsorption, no comorbidities. Young lady, obviously, all immunological profile perfectly normal. Finally, we did design a regime for her. The amount of suffering and the mental agony that the family and the lady went through was just unimaginable. One time I was getting daily night calls from the father, and some point I had to say that you can't call me like this at 11 o'clock in the night. So I am available in the hospital at these times. You can come and meet me or call my team during the daytime. Please don't call at night. I sleep early. So I had to stop that. So it went like that. Again, this was a success story because this lady came to me day before yesterday to my OP, perfectly cured now. With only problem is that she's all red colored because of the clofazimine that we gave to her, and she's getting married in September. So she came also to invite me for her marriage. So we do have success stories, but the suffering that she went through, probably, we needed a bit of for the pain and all the suffering that she was getting. But then many of the cases, not TB alone. So various comorbidities, TB and COPD, very common comorbidity. And TB is a risk factor for COPD. So current gold guidelines say that among patients who are cured of TB, around 20% plus actually end up with COPD. And people with COPD at higher risk for TB. It's one of the major population attributable risks for TB. Something that is not recognized. One of our meetings some time back, I'm talking about 5-10 years back, where the health secretary of Kerala was doing a review, and district TB officer after district officer was trying to explain death due to TB in the district. And they were all having an explanation that people did not die of TB, they died of COPD. And finally, the health secretary turned to me and said, Sanjeev, you claim success for having developed the COPD program for the state. Then why is it that TB patients are not getting access to COPD care? So, it's just giving them care for COPD, which also doesn't happen. But then it's difficult. TB itself is causing lung damage. You have already damaged lung due to COPD. So they have severe increase in cough and dyspnea. The debility adds with both diseases, and hypoxia is also something that needs to be managed. Diabetes is another major risk factor for TB. State of Kerala actually has about 32% of their TB patients having diabetes. Works the other way around also, where poor control of diabetes can lead to TB. And often diabetes leads to other complications like renal failure, visual problems, which actually complicate the treatment and also make it difficult to give treatment because you're not sure whether your ethambutol or linezolid is causing the toxicity or whether it's due to diabetes. So you have all kind of complications as well. Now, this is something that we are facing more and more these days. So TB and cancer, very common scenario in Regional Cancer Center Trivandrum, where they do a mastectomy for breast cancer, and then they do axillary sampling for looking for secondaries in the axillary nodes. And the node comes as case-eating granuloma consistent with TB, and the NAT comes as MTB detected. So now it's a question of CA breast is already proven. Patient has to go in for treatment for CA breast, and they also need treatment for TB, which goes together. But then this man who was, getting palliative care for the CA, the upper respiratory tract, had a tracheostomy done and had a sudden increase in cough. And the palliative care, I don't think it was a doctor, palliative care team member, maybe it was a doctor who recognized that the cough was very different from what he had earlier, and then managed to aspirate from the endotracheal tube and send it for a nucleic acid amplification test, and that came as positive. He also had fever, weight loss, and all, which that person could actually. So X-ray lesions also were picked up later. So TB was detected. He was there in our ward for some time and a very sick man. But then the issue here is that we treat TB not just for curing this patient in this very sick patient. It's also the issue of caregivers and palliative care supporters. With a tracheostomy tube, if he's coughing, he's bringing out large number of TB bacteria out there and he'll be infecting other people. So that is also need to treat this patient, and he was already also on oxygen. So a difficult patient, which he was already on palliative care with his anti-TB drugs. The palliative care continued. So with this background, we would all agree that this is a need of the hour, that our TB patients definitely need palliative care. So what do they really need? So when you look at it, the major problems are, incessant cough. So bad, the cough is so bad that the cough itself causes chest pain, rib fractures, and all that. Intolerable dyspnea in many of patients, particularly if they have COPD and TB and all occurring together. It's almost as bad as interstitial lung disease or even worse. Massive recurrent hemoptysis can occur on patients, very life-threatening as well as frightening for the caregiver and the patient, something that we can address. Pain, chest pain is one of the cardinal symptoms of TB, which again is quite severe in many of our patients. General debility, which is part of the disease, obviously, that is how we diagnose TB. Hypoxia, when you have bilateral extensive disease or, the thing, you have these, like the other case that I showed, patients who have a pneumothorax or a bronchopleural fistula or empyema where the tube cannot be removed. So they go with the chest tube for such a long time. Of late, people get worried about it. There was a time when I was a postgraduate student and we had a patient with a chest tube for 9 months and who went back home after removing the tube. These days, probably, unethical and proper to do that, but there were times like that. And of course, multi-system dysfunction with any organ in the body can be affected because of TB and they can have suffering to that. Now, if you look at this, one of the things what is missing is that many of these things can easily be addressed. So your incessant cough, the intolerable dyspnea, all that can be accessed. Even the other day, Dr. Ajagopal in a session was telling me, Sanjeev, your patients can easily benefit from morphine. He said they're not getting even lower dose of morphine are good enough. But then, where do I get my morphine? So I have no access to morphine. In the good old days, when I was a student, whenever a patient came with a massive hemoptysis, the immediate drug was the injection morphine, which would be very beneficial to the patient. Today, again, that is not accessible to me. Pain is also something that your morphine can deal with. So all these things where, at least now in the college, I have access to my palliative care team who supports me by offering the right drug. But many of the doctors treating TB do not have access to morphine. Because nutritional support is something that is good for improving the overall care and as well as general ability, which the government supports. There's a Nikshay Poshan Yojana. Each state has we have to link the patient with those schemes. Hypoxia is something, often you can take care of it by oxygen, ventilation, non-invasive ventilation and all that. But doctors are reluctant to take care of TB patients with a non-invasive ventilator or a ventilator because of risk of infection, both to the medical team as well as to other patients in a closed ICU and all that. So often, even though those things are available, your TB patient may not really get access to a non-invasive ventilation and things like that. Surgical care is often sadly missing in our Indian TB patients. They could actually gain a lot by good thoracic surgery access, but then that is very difficult in most parts of the country. And other specialties also. TB is a disease which everybody wants to ignore. And when you have other specialties who are asking for consultations, they are worried about going to MDR TB patient. So you don't get the optimal care for your patient, which could actually be good. The other issue is, of course, pulmonary rehabilitation, which is also something that the program is trying to develop. For the TB program, often they mix up pulmonary rehabilitation with palliative care. For people who work into palliative care and for rehab, for us, there are quite a few differences between the two. Of course, there is a lot of overlap. Other modalities like surgery, psychosocial support, psychological mobility often not being addressed, and end of life issues also, we really don't have a proper way of addressing in the TB program, which is totally anonymous. Now, when we look from the other side, look from the palliative care side, one of the major issues to remember is that your TB patients are infectious and it is through air, So one of the old World TB Day slogans said that, every breath counts, stop TB. Now you can't stop breathing. So everybody breathes, and as you breathe, you're spreading TB. So, it's not like HIV or many other diseases where you can easily prevent the spread of infection if you take care. As in TB, the spread is more possible if you don't take extremely good care. So you have patients coming to palliative care centers who are susceptible. Your malignancy patients, most of the patients coming to palliative care centers are susceptible to TB. So in the mix of that, if you put one TB patient also, all these patients are at high risk of TB and progression. And also the risk is there for health workers as well. So that is something that we need. And there's also this issue that in, say, in malignancy, if a patient is reaching, end of life and having a lot of suffering due to the drugs, the decision to stop those drugs and, continue with the end of life care is the decision is easy. Whereas in TB, the problem is that the moment you stop drug, because giving drugs is the best way of reducing infectivity in your patients. So the moment you stop drugs, you're probably putting those caregivers and supporters, medical supporters at risk. So should we keep pushing the medication despite the patient suffering to protect the caregivers and the community? That is a question that is very difficult to answer. It's a very tough thing. For the patient is suffering because of medicine, so I want to stop the medicines. But if I stop the medicine, the patient would become infective and might infect the others. So should I not protect the caregivers and the community? It's a very difficult decision to take. So the support is quite easy in terms of giving opiates for reduction in cough and perceived dyspnea, supportive care in terms of pleural drainage, oxygen, management of general disability, take care for nutrition, bed sores, and all those things. Management of comorbidities, well, like COPD or malignancy, so that the added suffering is reduced, and of course address end of life issues in whatever way you can. Now, that was what can be done, and we just move on briefly to what is being done. So, like I said earlier, it's not much is being done, but still, what is really being done? So, there is a WHO document which came out in 2020, which addresses the palliative care need of for TB, particularly in the 18 high burden countries, high priority countries, which includes India. So, WHO is aware and has got a strategy for it. Our country, in the MDR TB document, it's not the journal TB document, in the MDR TB document has put in a chapter on palliative care, which is a big thing. So it's putting in a chapter. I'm sure that many of the experts here have contributed to that. And the good thing which I liked in this is they said that palliative care doesn't begin at the time when the patient is about to die. It begins at the time of diagnosis, which is a very important statement for a TB guideline. So it says that it begins at the time of diagnosis. So from the very beginning, you have to address palliative care needs, not when the patient is about to die. And regardless of whether he is expected to be cured or would we fail the treatment. So we get in early and provide the right kind of support. And it also lists the kind of services and supportive care that should be there for TB patients, which for palliative care, which include addressing pain and symptom control, including respiratory insufficiency, nutritional support, need for medical intervention even after treatment cessation, which is very important, including the psychological morbidity, which may not go with just patient being declared as cured. Ensuring appropriate place of care, preventive care, infection control, and end of life. So all these services are listed out and should be offered to TB patients. And the other side, the supportive care include pulmonary rehabilitation, most of the other things including, vocational rehabilitation, and ancillary drugs being provided to patients, and respect for patients' beliefs and values. So all these things are actually addressed. It also gives a bit on the support and infrastructure. Generally talks of a team of physicians, nurses, and health professionals who would actually make a palliative care team, but they are expected to work mainly with the primary care physician and referred specialists who are actually available in the health system. And also, this has to be initiated by the nodal DRTB center, which is the center which should ensure that all these things are done. Preferred is home-based care, particularly because TB itself leans towards domiciliary care. So, and it's better for patients as well as the community by doing home-based care. But if you have end of life issues and other home-based care not being feasible for your patient, then you need to provide institution-based care, which the guideline says should be provided in some of the older TB hospitals which have more space and which have facilities for infection control. The nodal centers are expected to counsel and train family members as well as other caregivers of the patient to actually ensure that palliative care comes in, and also build a team of community-based workers, which is available in places like Kerala, but may not be available in other parts of the country. There's also, a documentation there, which is important because government machinery works only when something is put in by black and white in a document. So it very clearly says that you have to work closely with interested NGOs or faith-based organizations. So this coming into a government guideline is a big thing, with indoor facilities that can be engaged through a MOU guided by the nodal center. So the fact that this is there in the guideline allows many of us to actually engage with these providers, and all healthcare workers should receive training in palliative care. And it also talks of linking up with local palliative care and hospice teams from the network of Pallium India and Indian Association of Palliative Care. So this is actually put into the document, which actually gives me a lot of freedom to work with organizations like Pallium India. So nobody would question me, why you are working with that organization? Why not this other organization? Because it's there in my document. It's there in black and white. And it's easy for me to follow now. So this is a major achievement that all these things have come into the document. But sadly, despite all these things coming in, it was not really happening. So then the country decided to develop about something they called centers of excellence, where all aspects of care for TB will be provided in such a good way that they would become model for other things. And they assigned the first few centers of excellence, which included a few in Delhi, Tambaram in Chennai, one in UP, one in Mumbai, JJ Hospital. I had gone for the evaluation of JJ Hospital and the Rajan Babu Institute in Delhi. At the end of this evaluation, what we found is that palliative care and pulmonary rehab are the two things which are not happening in any of these even so-called centers of excellence. So most of the other things like pediatric care or HIV, TB care, all those things were happening, but then these were things which were not happening. And in its wisdom, the leadership of the TV program felt that since these were not happening, let us remove this from the checklist. So I said, no, sir, that is not done. These are extremely essential. So if at all it is not happening now and you want to assign certain centers of excellence, let us keep them on the checklist. For now, let us say that those are desirable and not essential. So that at least you can assign your centers, but with the understanding that these centers would actually develop those facilities later. So with that background, the International Union Against TB and Lung Disease, who are actually facilitating that meeting, they also felt that this should be developed. So they decided that the Rajan Babu Institute in Delhi would be the model center for pulmonary rehabilitation, and the Tambaram Institute in Chennai would be the model center for palliative care, and we would develop a perfect palliative care system there, which should actually help other centers to also take up the same activities in a good way. So these were some of the inspections that we did, and then finally, we had a team meeting up at Tambaram, including you can see Dr. Rajam also in the meeting. So they all got together, and a draft document came out. The first document, unfortunately, did not take off. So there again, we have to understand that a pulmonologist, out and out pulmonologist treating only TB and lung diseases often doesn't understand palliative care well. And if the document leans heavily towards palliative care, which does not give them a comfort, they will not be able to take up the thing. So you need to meet them somewhere midway and also take them into their own comfort zone. So that is being now developed. Dr. Ajam is again part of the team, and we are developing the next document. Hopefully, palliative care would take off in a big way. And I am also hoping that we will be able to do something in Kerala also. So that is also in the So I'll conclude by saying that a significant proportion of TB patients do need palliative care. The numbers, even if you talk in terms of 10% of TB patients, you're talking about 2.8 lakh TB patients every year. So that keeps adding on every year after year. There is a unmet need for palliative care and TB in India, which is neither is there is awareness for that, nor are the facilities available. Early efforts have been made, including many of us, Dr. Ajam and me, and all have been doing our little bit for that. To integrate palliative care to TB care, but that's a long road ahead for that. And the other side also, the palliative care services also need to adapt themselves to take care of TB patients, because often we find that as a clinician treating TB, when we refer our patients to palliative care centers, they don't know what to do there. So they often think, why is this patient referred here? And the patient comes back without any care. So I think that is also something that the palliative care centers have to understand, and those cares have to be met. Thank you. Thank you for the patient listening. It would have been better face to face, but I think this is what is allowed in today's post-COVID era, where you sit on a computer and speak.
But
Fortunately, I
it's
can
also
see
great
Dr. Rajam,
coverage,
so
Dr. Nair,
yeah.
because we have reached out to a lot of doctors across the country. Once again, extremely important. I want to ask a very honest question to all our pulmonologists. How many of you have, after attending these sessions, realized that we could do palliative care in tuberculosis? Just put a hands, raise your hand. And it's very, very important that, like Dr. Nair mentioned, such a neglected field. And Dr. Nair, just that last point that you said about training palliative care physicians of how to look after tuberculosis is what the communication I've had with MSF, because they have worked so much in the field of tuberculosis. They're happy to train palliative care physicians on how to look after infectious TB patients. So we thought we'll have a half-day training session, one face-to-face for from Mumbai palliative care physicians, because they're based out of Bombay. And I've also spoken to Pallium India to rope in their doctors so that the pulmonologists who are looking, so the palliative care physicians who will eventually look after TB patients are also given the enough information handheld as to how they should look after patients when they go home or the patient comes to the OPD. So it's a point well taken. Even we need to train ourselves, especially palliative care physicians. Like you said, we cannot afford to disappoint these patients, and we need to look after infectious TB patients in a productive manner so that we can, help them, help their caregivers. So that's an excellent point. And that's why we have Dr. Aparna Iyer. Do you 1 minute before I go to that? Dr. Nair, 3 participants have raised their hands. So I think there are people who are already thinking of integrating palliative care. So thank you to Dr. Jay
If I'm
Kumar.
allowed, Dr. Rajan,
Yeah.
Dr. Preeti is there in that list who have
Yes,
raised
she's
the
the
hand. So Dr.
HOD of
Preeti is
JD.
actually from one of the
Yes.
centers of excellence, and
Yes.
she actually has developed a good rehabilitation center there, which was
Yes.
missing when we did the initial evaluation. So she has established a rehab center. So I was
Yes.
just wondering whether Dr. Preeti, whether the palliative care services could also be developed, or is
So
it
she's
still
just
limited
signed an
to a...
MOU. I'll request Dr. Preeti to unmute and speak. But she's had, yes, welcome. Good evening.
Good evening. So we have hello everybody. So we have kind of have a MOU with King George V Medical Trust, which runs a palliative care center in Mumbai. So we are trying to go further from the rehab to a palliative care center at our setup. So it's just the first few months. Let us see how it goes.
No, that's
That
why
is
when I
very
met her
heartening to hear.
personally, MSF had a one-day conference trying to marry private public hospital, the government initiative, as well as they had invited palliative care physicians. I met Dr. Preeti there and said we should work this together and improve the integration and see to it how we can. And in the side by side, parallelly also train and handhold palliative care physicians as to how to look after TB. It has to be both ways because otherwise it will be neglected. So I think Dr. Jayakumar Rajgopal wants to discuss one point. Dr. Nair, if you will just check the chat box, maybe endotracheal intubation and morphine will limit the spread of TB to caregivers and community during end of life care of TB patients instead of keeping them open and spreading. We should not neglect them. It sounds crazy in a palliative care lecture. So do you want to take on that? Then I will give my viewpoint on that.
Yeah, I'll read, Dr. Adam, if you can take over. I'll try to understand.
Yeah.
Yeah, I mean, I'm not sure whether about the endotracheal intubation part. So infection control in TB is a big thing, So we are doing a lot for that as well. So in terms of infection control, I think just having open spaces and good air circulation and all is good enough to take care of it. So we need not actually put a endotracheal tube for the patient for that particular purpose. So I can understand giving morphine, reducing the cough frequency will actually definitely reduce the spread of TB. So your point is well taken, very good in that. I mean, our issue is, of course, accessing morphine, but then if the patient has an incessant cough, each time he coughs, he's bringing out large number of bacteria. So of late, there is a lot of evidence that cough frequency is related to spread of TB. So if we can actually give relief to his cough, not just to prevent the spread, our aim should be to reduce his cough and suffering. But when we do that, we also byproduct would be to reduce the spread of infection. But then I think having a good cross ventilation room with good circulation is good enough to prevent the spread of TB. And a good, I mean, we could actually, help the patient wear an ordinary triple layer mask would actually reduce the spread of TB for the patient. Of course, for the caregiver, we can provide better things like N95 or something like that. But then in a household situation, a person wearing N95 24 hours is also not feasible. So we have to think of other ways of reducing infection spread. So we have to take care of the caregivers. Totally, your point is well taken. I agree with you fully, except for the intubation part.
I also agree. I don't think endotracheal intubation or anything invasive should be done. And I agree with all the other points. And yes, it is very important and a part of palliative care to look after caregivers as well as ourselves. When we go to look after these patients, we also need to look after ourselves, which is equally important. Dr. Madhav Mahavar and Dr. Chaitanya, do you want to share something by unmuting, or should we go ahead with the case? And before we go to the case, I would just like to ask Dr. Aparna Iyer to let us know if this kind of a forum to train palliative care physicians is ideal for MSF so that we can look after patients better. Dr. Sanjay Pandya has commented something, changeover of healthcare giver as long-term contact can be avoided. Yeah. So you mean rotation, point taken. Go ahead with the case, Chaitanya. Dr. Madhav, do you want to share anything?
Yes, ma'am. Sorry.
Yeah.
I was
Yeah,
a
Dr.
bit
Aparna. So Dr. Aparna is from
confused.
MSF, Dr. Nair. And
Yeah, I met her.
you
I know.
met her.
Yeah.
Okay, go ahead.
Yeah, hi. Yeah, Dr. Nair, Dr. Rajam, thank you so much, and hi, everyone. So, from MSF side, in our clinic, as we were catering to most who are used to in last couple of years, Tuberculosis and Delaminate exposed patients also. Those patients we started treating with imipenem salvage, and we saw these patients also failing treatment. So for us, that was one of the things that none of the drugs were working, and then we had to declare them on palliative care. And then we had collaborated with a palliative care physician who was working at KEM, and now she's in Tata. And she used to get some, symptomatic treatment for these patients. And our team had a small team were going to the household to give symptomatic again support and home-based care. But yes, this is a huge area, and you all are like a lot of experts are here. So we would like to take this opportunity to thank you all to make us participate in this forum. And also, as Dr. Raja mentioned, we are looking forward to train and capacity build with whatever experience we have got, and also to collaborate with you all to establish palliative care for TB, because we also provide oxygen concentrator support for these patients, and we know it's very difficult for the patients to maintain these, and we want we are looking for partners who can take in for this provision of support for these patients for the long run. Our plan is also to reach out to Shivri to see what we can do at the Shivri hospital. And now that Dr. Preeti Meshram is already here, so we'll also see how we can collaborate at JJ.
Yeah.
So yeah, I thank you all, and of course we are open for training and capacity building. Thank you so much.
Thank you. So shall we just go ahead to the case, Dr. Nair?
Yeah, sure.
Yeah, Adarsha Shetty, I think, is going to present the case. So we can go ahead, and then if we can do it quickly, then we can have some discussion on the case. So over to you, Dr. Shetty.
Yes, ma'am. Thank you, ma'am. Okay, I'm Dr. Adarsh Shetty, working as assistant professor in KSET Medical Academy, Mangalore. So I'm presenting a case of a 56-year-old female who was diagnosed to have right upper lobe fibrocavitary lesion, which is sequelae to TB. And the patient also had complications of pulmonary hypertension and cor pulmonale, and she also had comorbidity of systemic hypertension. So she had presenting complaints were like breathlessness, shortness of breath for 15 years, which were aggravated since 15 days, and cough with sputum for 15 days, easy fatigability for 15 days, intermittent fever for 15 days. History of presenting illness, patient had breathlessness since 15 years, but aggravated since 15 days. Which was insidious in onset and progressive, progressed from grade 2 to grade 4. And patient also had orthopnea. And the cough was associated with the yellowish sputum. And there was history of easy fatigability for 15 days, and fever, which was intermittent and low grade. And there was no history of chest pain, palpitation, or syncope, and no other complaints. Past history, there was history of TB 15 years back, which was microbiologically confirmed drug-sensitive TB, and the treatment was taken for 6 months, and there is history of multiple hospitalizations due to recurrent lower respiratory tract infection, and she's a known case of hypertension and taking Telma for TMG BD. There was no history of diabetes or coronary artery disease. Personal history, appetite was decreased, and bowel bladder habits were normal, regular, and family history, Patient's father had TB 20 years back, taken treatment for 3 months, who used to stay with the patient and died 3 years back due to respiratory illness. General appearance, patients built poorly nourished and average built. Vital signs, BP was 150/90, heart rate was 106, tachypneic, saturation was 84% on room air. Bilateral pitting pedal edema was present and clubbing was also present. Patient was pale. So on inspection, examination, respiratory system examination on inspection, chest was asymmetrical, apex beat was not visualized, right shoulder was drooping, and trachea was shifted to right, lip crowding was present, chest movements were reduced on right side, infraclavicular flattening was present. On palpation, inspectory findings were confirmed, and vocal fremitus was increased over right infraclavicular, supraclavicular, and supra and infrascapular areas. And measurements, chest circumference 84 centimeter, left hemithorax 43, right 41, AP diameter is 20, transverse is 24. Percussion impaired notes were heard over right supra and infraclavicular, supra infrascapular areas. Resonant notes were heard all over areas. Auscultation, bilateral air entry present, cavernous bronchial breath sounds heard over supra infraclavicular and axillary areas. Vocal resonance increased on right infraclavicular, supraclavicular, supra and infrascapular areas. Crepitations heard over right supraclavicular and suprascapular area, and the left infraaxillary and mammary areas. In cardiovascular examination, there was elevated JVP and loud P2 was heard. And per abdomen examination, it was soft and non-tender, no palpable organomegaly. Chest X-ray, you can see there is tracheal deviation to right side and volume loss on right side, and there is evident shift of lower mediastinum to the right side, and there is volume loss. X-ray already discussed, and echo showed there is right ventricular hypertrophy, dilated RARP, and severe pulmonary hypertension. ABG showed type 1 respiratory failure, and sputum investigations revealed it was negative for AFB and the CBNAT, but culture had grown Pseudomonas aeruginosa. Treatment, IV antibiotics were started as per sensitivity pattern, and oxygen was supplemented, and Lasix was furosemide was used for managing this fluid overload and right heart failure. And bronchodilators, inhaled beta 2 agonist anticholinergics for symptom relief were used, and advised high protein diet, and palliative care consultation for symptom management, but it is not available in our facility. Medications which we used in our hospital was nebulization with the Diolin, Itaverli, injection meropenem for treating Pseudomonas infection, and injection pantocid, Lasix, and mucolytics were used, and then protein powder. Psychosocial aspects, in this case, it's a chronic lung condition, post-TB fibrocavitated disease with core pulmonale and pulmonary hypertension. And it encompasses a great challenge and consideration that affect the patient's mental and emotional well-being, as well as their social interaction and support system. So emotional impact, our patient experienced a range of emotions, including anxiety, depression, frustration, and fear, coping with the chronic condition, chronic nature of this condition, and it impacted our daily life, and the concerns about future significantly affected our emotional state. So quality of life, regarding quality of life, due to the persistent respiratory symptoms such as cough, dyspnea, recurrent infections, her physical functioning was affected and reduced her overall quality of life. She struggled in her activities of daily living, social participation, and leading to feelings of frustration and isolation. As everybody knows, the TB is still associated with a lot of stigma and social isolation. So that is also a concern. And financial strain, the economic burden on our patient, including costs associated with multiple admissions, contributed to financial stress due to her low socioeconomic status. So main concerns were preventing repeated infections and providing a psychosocial support and chest physiotherapy and end of life care. To summarize, a 56-year-old female with low socio-economic background with advanced chronic lung condition with complications of that condition leading to corpulmonal cyst and then psychological issues. And she probably required palliative care consultation, which we didn't have. So this case outlines the need for the palliative care set up in every health facility to ensure end-of-life care for patients who are having chronic debilitating respiratory condition. Regarding discussion in this patient, as there is no facility for palliative care, especially end-of-life care in our facility, suggest further steps to go about this case to provide her good end-of-life care. And regarding psychological counseling also with the counselor, and the role of pulmonary rehab in this patient, and is there any indication to use opioid in this patient to relieve her chronic breathlessness syndrome? Thank you.
So thank you very much, Dr. Shetty. Very relevant to what was told earlier by Dr. Nair. So, and therefore, and also very honestly admitted that, not all centers unfortunately have palliative care. But the whole purpose of this integration of respiratory physicians with palliative care that Pallium India has taken an initiative. Today is the 11th lecture and the last lecture to finish this. I'm glad that all of you have started thinking laterally about not just cure, and let's make the patient symptomatically better, but what else we can do. And that, I think, is the big point and purpose achieved, that we start thinking laterally about referring to palliative care. So each of you, now that you'll have had this training, should be able to wear that palliative care hat for this particular kind of patients that you see. Keep these patients towards the end of your OPD, because they might need a little bit extra time. And like you said, unfortunately, all hospitals and all hospitals do not have palliative care. Hence, please ensure that your residents also get trained in this palliative care when we have future sessions, so that they also can start thinking of when to stop doing aggressive invasive treatment and really start talking to patients of what they want. And that is exactly what is good end of life care. We really need to know what patients desire, and we need to start thinking of medical ethics, of autonomy, best interest, do no harm, and justice. And in a field of tuberculosis, I think justice is very, very important, because there can be another patient who can be given those medications who can return to good quality of life. So obviously, this patient of yours would have benefited by integrating palliative care. There is no doubt about that. Because it's a multidisciplinary team, it would have taken care of the psychological issues. It would have taken care of returning her to decent quality of life if integrated early through pulmonary rehab, and also helped her to control her symptoms, because we might not have been able to cure all that was going on in her lungs, but control her symptoms with low dose opioids. So please do remember the profile of patients where you can start thinking of palliative, when to integrate palliative with that surprise question, and in your own little setup, try and see if you can rope in some social worker or a psychologist or the physiotherapist to see to that we can improve our lives. And then slowly, hopefully in the next decade or so, we should have a palliative care department in every hospital, like we have a casualty and emergency department. But Dr. Nair, would you like to add anything? I'm sure these are the kind
Dr.
of
Adarsh,
patients you
yeah,
see
yeah,
very often.
exactly. I think I totally agree with Dr. Ajam. I think a very good presentation. You brought out a lot of all those things which we face day in and day out. These are our, normal patients. These are kind of patients who keep coming to our OP in most hospitals in India most of the time. So we are all used to seeing these patients. I think the important thing, like Dr. Ajam said, is like 10 years back, we would not have thought of palliative care in this. We would have thought of all kind of curing each aspect, but now we learn to think of a few points that I want to add further to that is, one is COVID did a lot of good things for us. So before COVID, when we did the SHWAS program and when we went to our association, the pulmonologists went and met the health minister of Kerala, who was very good minister, as you know, she's on all over the world. We spoke to her on the need for oxygen for patients. So this particular patient that you mentioned has respiratory failure and has pulmonary hypertension. So definitely, I assume that she would gain from long-term oxygen. For a long time, that was not accessible to our patients. But post-COVID, so many oxygen concentrators and all were purchased that at least in Kerala, people have more access, even with financial difficulties. Many of the panchayats and many of the NGOs have oxygen concentrators which can be provided to patients. And that is one option. So again, all these things that the patient needs, we need to also think, you very rightly pointed out about the financial difficulty that the patient has. So you can actually link up with the system. There may be facilities available. So, send a patient to palliative care. Neither the palliative care team knows what to do and what could actually benefit this patient. So this particular patient, we could also give our suggestions that this patient could benefit from long-term oxygen if your ABG is appropriate for that. And then the patient, the team could actually link up with supporters, donors, and all that, and get a oxygen concentrator for the patient. The other thing which again works well in field conditions is patient support groups. So many parts of India, particularly in Kerala and all, we have these cured patients groups. And those groups actually work together. And one of the very important points that you raised was the need for psychosocial support. So this lady who has been sick for 15 years, who might be in and out of hospitals all the time, maybe, having a lot of guilt as well as anxiety at home that she's not able to contribute to the family well and that she's sick
Yes.
all the time and continues to be sick. So for a person like this, generally, like you said, when you meet them, they are anxious, they are depressed. On the other hand, when they go for these patient support meetings, when they meet people of the same kind of, illness and all that, they feel that more of hope and some satisfaction comes out of it. You rightly pointed out on just physiotherapy, we need to add rehabilitation also. Here, the point here is that here the palliative care and rehabilitation, like I mentioned in my presentation, the division gets a bit blurred. So nutrition comes in. Obviously, you put in nutrition, vaccination, and all, which are part of rehabilitation, but a bit of exercises and all, which again, as part of community groups, when you do group exercises, group things, find the depression also goes. People have a support system and they feel happy. I don't know how much it's doable. Again, like palliative care, rehab is also something which is very poorly available for our patients. So these are some of the points that I could think of immediately. But I totally agree with Dr. Ajam that the very fact that we have started thinking of palliative care needs of these patients itself will obviously lead to those systems coming into place. So I think that is the
So just to add to this, Dr. Nair, we are also planning to train Pallium India physiotherapists as well as doctors in pulmonary rehab. So this 11 sessions for pulmonologists had one session of pulmonary rehab also. So that, little bit when you're giving the prescription and talking to your patients, you can emphasize the need for rehab and also teach them some basic exercises so that, because apparently in Kerala, there is a little bit of, dearth of specialist cardiopulmonary physiotherapists. So the one from Bombay is going to actually do an online session. We are going to put up a schedule. So if you also have interested people or physiotherapists who are keen to learn, please connect with Pallium India. We can have a joint session. So that will be win-win for everybody.
That's great news. I think, but Dr. Adam, one more point, like what
Yeah.
came out in the presentation is that, in many parts of India, we have excellent centers for palliative care. We have excellent centers for pulmonary rehabilitation. But like he pointed out, it is not accessible to a significant proportion of our patients. So
Yeah.
I think the challenge for us is not just to have these centers of excellence, but also to ensure that it goes out everywhere. So like I said, in Kerala, the panchayat level palliative care system is quite strong, but those, like we discussed a bit earlier, they may not know what to do for a patient like this. So that also needs to be done. I think that is something that we should definitely work together towards.
Yeah,
Thank you.
absolutely. Absolutely. Anybody has anything else to add or say or discuss? But thank you all for the case, and thank you, Dr. Nair, for yet another excellent presentation. And it's extremely important to talk to pulmonologists so that next time you see a patient like this, your antenna is completely raised, and you know what exactly to do, or handhold the patient, or refer ahead, or find a local support. The second thing I wanted to tell you all, that the Indian Association of Palliative Care has a directory. So please check the directory if in case you want to send a particular patient to palliative care. If possible, call up that particular department to say that this is the condition, so that there is a connect and these people will recognize the patient that you referred to. If you put in the area you're looking for, you get the contact number and details of all the available palliative care contacts in that particular region. Yes, unfortunately, there are still many regions to be covered, but it's a fairly comprehensive directory. So please utilize that from the Indian Association of Palliative Care website. Also, thank you very much for joining for these sessions and being a very enthusiastic audience. All of you have interacted, and I know I have shared 2 cases with you all for as homework. We will, get back to you once I receive all the Google Forms. We'll get back to you by individual emails to see what best you have done and what more can be done. It's a learning process. Thank you for having the interactive sessions, and we hope to see you all again sometime in person, or through a Pallium India virtual meeting. So thank you very much, and thank you, Dr. Nair, and look forward to working with you and continuing to see to it that TB and palliative care are integrated well in this country. So thank you.
Thank you for the opportunity.
Have a lovely evening. Thank you. Over to Pallium. Who is there today? Sangeet?
Yes, ma'am. I'm here.
Yes. Yeah.
Thank you, Dr. Sanjeev Nair, for the wonderful presentation. Thank you, Rajamaya, for facilitating the entire sessions. So we are hope to receive some feedback for these sessions. Dr. Sanjeev Nair, you can leave if you wish. We hope to hear from the participants itself. Please, everyone, kindly play feedbacks about the program, about the sessions we have conducted.
Another thing, Pooja, did you manage to communicate with Anna?
Yes, I did. Thank you. I'll loop you in the email.
Great. Yeah, please do.
Thank you so much. I really appreciate it.
Just realized that when I saw your name.
Thanks.
Bye. Good night, everybody.
Bye, ma'am. Good night, ma'am. Bye. Is there anything you want to tell about these sessions, how it impacted in your journey throughout? We would love to hear from you. Dr. Uttara, please go ahead.
Yeah, Mr. Sangeet,
Yeah.
it was, very much different from what I expected. And I think the faculty did a great job, especially, keeping everybody's attention intact on an online session is very difficult, but they did that with a lot of ease. And the topics were also very nicely spaced out. So I think you did a great job putting up the schedule, and the exercises that were given also were quite useful. So yeah, I think keep up the good work, and keep doing these sessions, and we can also spread the word because we have attended it, so we can encourage others also to attend the program.
Thank you, ma'am. Thank you for your kind words. Thank you.
Yeah, thanks a lot.
Is there any other one wish to convey some messages? Okay, I hope this is the end. Okay, thank you all for being the part of journey for this Pallium journey. Thank you all. Let's see in the next next program. Thank you. The WhatsApp group will be open for everyone. So if you have any doubts or queries regarding the sessions or any doubts, Dr. Rajam and Dr. Hashmat will be ready to answer all your queries. So please be in touch. Thank you.